Good morning, everyone. Thank you so much for braving the snow. I was so stressed coming in. I almost thought I won't make it on time. So thanks to everyone who's here in person and those who've joined online, maybe the smarter ones. I am sorry. So it's my pleasure to introduce this trifecta of three phenomenal people. So when I was thinking, okay, I have to keep it brief because this can't be a grand rounds in itself reading through their CV. So I'll keep it brief. I'll do it in alphabetical order. And I'll highlight a few things about these three incredible people who are doing amazing work in type 1 diabetes. So first, Dr. Libman. She's a professor of pediatrics in the Division of Endocrinology, longtime Pittsburgher. Did her PhD also here. She holds a secondary appointment in Department of Epidemiology, School of Public Health. She is director of the diabetes program and the diabetes transition program. And she's an internationally recognized physician scientist with extensive expertise in pediatric diabetes. She has published numerous publications and she leads multiple national and international collaborations, including the Today study and type 1 TrialNet, of course, for which more than 2-decade-long study for which she's the PI for UPMC. She's a dedicated clinician, educator, and mentor. She's won many awards. I won't list them, including University of Pittsburgh's Allen Humphrey Excellence in Mentoring Award. She has been involved right from the conception of this idea. I remember the day way back when Chris Gessner was the president, and he introduced us to Ken Nash, who had started this program for children with mental health disorders. She's been involved in this program right from the beginning, and you will hear today about its incredible journey and evolution from a pilot study to a program that's actually supported by the UPMC health plan to help patients and families. I think that is a remarkable first step. With her through this entire journey, an incredible part of this program has been Dr. Amy Nevin. She's a pediatrician focusing on public health and service of at-risk populations. She's a graduate of University of Chicago Pritzker School of Medicine, and she's a clinical assistant professor here at University of Pittsburgh. She's program director of this highly successful program. They will tell us more about it. And this program helps children with type 1 diabetes. She has taken this further and replicated this curriculum to help children with sickle cell disease. And she actually serves as a consultant for this NIH grant presence, which it is about peer support to children with sickle cell. Dr. Nevin is also the founding pediatrician of the Hilltop Community Healthcare, a federally qualified healthcare center in Pittsburgh. I'm learning a lot about them and how important they are in this current environment. She's also been a tireless advocate, working with the city to pull down abandoned building, addressing poor housing conditions, lead poisoning, all in all, really, really committed to the health of children in Pittsburgh. And with two of them, last but not the least, he is least only because his name starts with S, Dr. Justin Schreiber, who is also part of this team, who's assistant professor of psychiatry and pediatrics here at UPMC. His journey is from bachelor's at UCLA to master's in public health at Boston University and DO at Touro University in Nevada, and then residency and a triple fellowship here at UPMC in pediatrics, general psych, and child and adolescent psychiatry. He's the associate program director of the triple board residency program. He's the medical director of the outpatient behavioral health services, as well as the whole child wellness clinic. He's involved nationally in many committees, including the AAP's national conference focusing on behavioral health, and on the task force to update the AAP's clinical practice guidelines for children with ADHD. So with this very brief introduction and without much ado, please join me in welcoming Drs. Libman, Nevin, and Schreiber to present their lecture entitled A Talk of Peer and Family Support for Children with Type 1 Diabetes, the Diabetes Wraparound Program.
Thank you so much, Dr. Mazumdar. It's a real pleasure to be here. As it was mentioned, I trained here. I have been here for a long time. It's wonderful to see so many familiar faces that are here in the audience. And it's even more wonderful when you can collaborate with people that did residency with you, like Dr. Nevin. So this is really, really a treat. So as Dr. Massunder was saying, we're going to talk about the diabetes wraparound program and our experience over these years. So we don't have any conflict of interest to report. And this is the outline for our talk. We're going to start at the beginning, recognizing a need. This was the beginning of our journey. Then we're going to talk about the high-fidelity wraparound program in mental health. Then we'll talk about the diabetes wraparound program, its impact in terms of care and in terms of the community. So let's start with the beginning. So we all know that youth with type 1 diabetes represent a vulnerable population. These are data from the Type 1 Diabetes Exchange. This is a consortium of centers in the US, mainly academic centers, and the data I'm sharing with you here is for almost 15,000 participants, less than 18 years old, that come from 62 centers in the US, including Pittsburgh, including our center. The graphic shows the trends in hemoglobin A1C by age. You can see in orange the data for 2016-17, in turquoise the data for 2021-2022. And you don't need me to tell you that if you look at mean hemoglobin A1C across the lifespan, is much higher in the pediatric and adolescent years. If we look at the data in a different way, this shows the percent of patients in blue that are achieving the American Diabetes Association hemoglobin A1C target of less than 7% by age group. And you can see that less than 20%, irrespective of the age group that we are looking, has this target or reaches this target of less than 7%. What is concerning, in addition to this, is that 30 to 40% have a hemoglobin A1C of more than 9%. And again, this is extremely concerning. We need to do better. Not only they are not reaching their glycemic target, but youth with type 1 diabetes are also missing medical appointments, and this has consequences. This is a study that we did with Dr. March and Dr. Miller, among others, and it's a cross-sectional study looking at diabetes claims with diabetes specialists for youth with type 1 and type 2, but we're going to focus only on the type 1 population, and the association between the specialist claims with acute care utilization. The data is for youth that had at least 80% enrollment in a commercial health plan from December 1, 2018 to December 31, 2019. And it's important to notice that it was a little bit more than a year because we would expect these kids to be seen every 3 months, so 4 visits at least in the year. The primary outcome was the number of ambulatory claims from an endocrine and or a diabetes physician or APP associated with diabetes diagnosis code during this study period. And you can see here the results, the number of ambulatory claims with clinician by type of diabetes. And I want you to focus on the type 1 column in the square in red. So if you look at the ones that had 2 or less diabetes clinician claims, it was almost 20%. And why is this important? And this is important because children who missed 2 or more appointments were 3 times more likely to have DKA and 3 times more likely to have a hemoglobin A1C more than 8.5%. So again, missing appointments, another problem in this population. What are other predictors of deterioration in diabetes control? And this is a study from 2012, one of the first studies that looked at psychological predictors of diabetes control. This study has been, in a way, replicated, including population here from Children's in a hospital in Pittsburgh, but I'm showing this study because it's one of the first ones. It involved 150 participants, mean age 15 years, mean duration of type 1 diabetes 5 years, mean hemoglobin A1C of 8.8, followed up between 18 and 24 months. And the group found 3 trajectories. The one they called meeting treatment targets with a hemoglobin A1C average of 7.2, one that was called normatively similar that had a mean hemoglobin A1C around 9, and a group that was called high risk that had a mean hemoglobin A1C of around 12. And what were the predictors of this subgroup membership in these 3 categories or 3 subgroups? Not only demographic factors, medical predictors that we would expect, but also there were some psychological predictors, including greater depressive symptoms, negative affect about blood glucose monitoring, and diabetes-specific family conflict. So what they concluded was that depressive symptoms, diabetes-related distress, family conflict, raise some teens' risk for poor diabetes management and control, and these issues may be important targets for intervention. This is later included in the 2022 ISPAD guidelines. ISPAD is the International Society for Pediatric Adolescent Diabetes, which has guidelines that come usually every 4 years. This is from the last one, 2022, where they talked, based on evidence from large population-based cohort studies, youth and young adults with type 1 diabetes are about twice as likely to be diagnosed with a psychiatric disorder. They also mentioned the importance of the interdisciplinary team that should aim to provide preventive interventions for youth with diabetes and their families. And they mentioned these interventions should emphasize appropriate family involvement and support in diabetes management, effective problem solving, coping, and self-management skills. So with all this background that I just told you, about glycemic control, predictors of glycemic control and management, we recognized that there was clearly a need to do more. Like Dr. Mazumdar was mentioning, a few years ago, this was before COVID, Dr. Mazumdar was talking with me and with Dr. Nash, and for those of you that know Dr. Nash, he's very enthusiastic, and he started talking about this high-fidelity wraparound program in mental health, and I think it took maybe 2 minutes to convince us that this was probably something we needed to look into in the area of chronic diseases, especially in type 1 diabetes. And I love this picture that Amy Nevin found or came up with, which represents a little bit the concept of wraparound for us. And we were talking about this today. In the drive seat is the participant, then the people that are in the bus are the family members, but then this participant and these family members need all the additional support that come with having a behavioral health condition, that come with having type 1 diabetes. So I think it's a really nice representation of what wraparound is. So now with this introduction, I'm going to invite Dr. Schreiber to tell us about the program in mental health.
Thank you. So the question is, why is a non-endocrinologist who's a triple boarder up here? And so my emphasis that I'm going to focus on is how systems can really transcend between behavioral and physical health. And as a triple boarder, and for all those triple boarders watching, to recognize that we see a lot of this in both working in physical and behavioral health. So this is an example of what, for behavioral health, a family identified as the many systems that they had to work with to be able to address some of the complex behavioral health concerns that they had. Through it in the legal system, the educational system, the CYF system, and really a small component of this was the therapist, the psychiatrist. And so really, I think for our chronic medical conditions that we work with, we can identify very similar types of issues of many systems. And really, families are set up to fail when they can't navigate these many systems that exist. And it's not by increasing the therapist, increasing the psychiatrist, increasing the inpatient psychiatry time. The identification was not what was going to help these families with very complex needs, which led to the development of the high-fidelity wraparound system or program. And really, this said that we needed to identify teams that could work with the priorities of families to help with addressing the many issues that were occurring to work with these systems. And so identifying plans that worked well for them and that they were able to lead, that Dr. Libman identified really driving the bus to be able to say, what should we be focusing on when we're working with these various systems? The goals that came from that are that we need to, first of all, be able to prioritize what families and youth really identify as most important for them. What are the things that are going to drive them being able to see this change happening to address the chronic needs that they have? How can we support them with supports that really are focused on people they trust, people that are in the community, people they can continue to work with for the many, many years that they're going to be addressing this? We all know this, that for behavioral health, which oftentimes are chronic conditions, and similarly for diabetes, a chronic condition, it is not for a year, 6 months. This is the rest of our life that we're dealing with, addressing this and wanting to make sure we have supports to be able to work with that. And so how do we support those natural systems that exist to be able to help with continuing to support them and working through these systems? And that led to the framework for the theory of change, we'll talk about, the principles which we'll kind of address throughout our conversation here about what really is part of high fidelity. And then these phases that exist with the idea that you can't have necessarily these lots of supports that are there all the time. We want to really empower families to be able to take the lead themselves. So initiate more early on, really support families to continue to develop the skills themselves with the supports around them, and then start to back away and then really phase out completely. So for those of you who talk with me, I know it's, I talk about motivational interviewing a lot. So the theory of change is really important. The idea of how do we really work with families to get to that point of addressing change. And we know that to be able to do that, we can't come in with just our own priorities. We have to elicit the priorities that really exist for the families that we're working with. And so really understanding those is a first priority. Maybe it's not to get an SSRI. Maybe it's not to get our hemoglobin A1C to a certain point. Maybe it's instead to figure out transportation so that we can get to our appointments. Maybe it's to figure out how we can get appropriate food. So identifying what those are. And then also, instead of just saying, who are the other systems that could be fixing that, working on that, how can we instead identify the people who are in the community that they trust and work with already? Maybe that's a coach. Maybe that's a neighbor. Maybe that's a grandparent. Maybe that's a teacher, someone that they really trust, they can work with, that they feel like they will continue to have around them and will work with them for many years to come. And then allow that to build some efficacy. So I like this. I think this really sums it up to say, when youth and families begin to believe in themselves and systems support their efforts, everyone works harder towards accomplishing their goals and towards recovery. And we know that this is not new. So I'm not describing something that just came out. This has been around for a long time and has been established within both state and federal funding, has established an initiative that both looks at how we continue to promote high fidelity and also how it can continue to grow and be researched to make sure it's the best possible solution for working with mental health. And so this has a long history with it. The team that is part of it, so like what does that high fidelity actually include? It's the youth and families, the natural supports that I mentioned, system partners they're working with, and then the group itself is actually a facilitator who helps to make sure that the program runs, that they're working with the families, and really importantly, a youth support partner. So this is a youth with lived experience, in this case with mental health lived experience, who's oftentimes a young adult who can really work with the youth. And then a parent who is a family support partner who's gone through the experience themselves of navigating systems with working with youth with mental health conditions. And we know it works. So not only has it been around for a long time, but it's been shown with evidence that it has improved depression, anxiety, and most important, impairment for the families that are struggling with significant mental health conditions. And also extremely cut costs. We know it is much cheaper than having people stay in inpatient facilities for long times, going into residential treatment facilities for long periods of time, and also mental health-wise, much better for the families and for the youth themselves. So this is an effective system. It improves outcomes. It decreases cost, and it's not by increasing the mental health supports through more psychiatrists, more therapists, more inpatient time. It is by working on systems with other supports. So therefore, something that can translate into various other things, such as working with diabetes, which I will now pass to Dr. Nevin to talk more about how that transitioned to the high fidelity wraparound program in diabetes.
Being a doctor is a huge privilege, and looking around here at the many faces that I recognize, I think we can say that a lot of this is really, really hard. But this diabetes wraparound program has really revolutionized the way I approach caring for patients, and it's been such a joy to do so. And what I really hope everyone walks away from today is knowing that even with the kids that are really, really struggling, we can have a huge difference on how they're doing. And I really want to have that be the core message here today. The wisdom that I've received from patients and families, and especially from my staff and my role with this team, has really allowed me behind the curtain what life is like with type 1 diabetes or any chronic condition. And really learning that all families do actually have unique strengths and challenges. And if we can identify these strengths and have people uncover what really matters to them and who really peoples their life through these small achievable steps, you can make a huge impact and attainable steps towards confidence. And that's really what this whole program is all about and what I'm hoping to convey today. But it's better in words of families. So here's words from a couple mothers that I've met. The medical community teaches a child how to stay alive, but it doesn't teach a child how to live. And it offers no advice on how to parent this type of child and avoid significant potholes. It doesn't help with fear and how to wrangle with it, so you can let your child go out in the world. It doesn't help with normalcy, restaurants, sleepovers, school trips, advocacy, and understanding medical technology and choices. Teachers are kind, but they don't understand how this affects tests and studying. Coaches are kind, but they don't understand how dangerous it can be and how much harder it is to train and compete. So Dr. Schreiber referred to this, but in general, what we're trying to say is that this is complicated. The child and family needs are complex, and there's overlapping problem areas, and families have completely different challenges. I mean, we've seen with our families, it could be divorce in one family, and it could be for another that their child's failing out of 10th grade. Some kids are amazing athletes, and others are gifted in art. And each one of these child-serving systems are in silos that don't speak to each other. We know this, right? The school, the medical insurance company, the hospital, all of us, friends, sports teams, school nurses, employers, et cetera. And that makes this really, really hard. And everyone has their own opinion about what should matter most to this family, which is key. So in adapting this mental health model to a type 1 diabetes process, it is this peer-based planning process with an emphasis of the peers with lived experience on how to share stories with empathy in a meaningful and intentional way without re-traumatizing themselves. So who is hired as peer supports in this program is of utmost importance. And I cannot say enough about the people with type 1 diabetes that have worked with me over the years and have raised kids with type 1 diabetes as teenagers and their strength in this role. It is really hard when this is your own life to be then living the struggles of diabetes with families that are in the thick of it. So that takes a ton of fortitude on the part of the workforce. And this is a very intense program, and that is why it works. So the peer supports meet with the parent and caregiver weekly. And on the mental health side, the average amount of involvement is about a year. We were a little bit under that. And they're integrating families, friends, professionals in monthly team meetings as well with concrete plans and action steps. So what does that look like? I mean, Justin referred to it, but here's my little elevator speech. So in the mental health side, say you have a child who's a teenager with bipolar disorder, really struggling. They would get connected with a young adult between the ages of 18 and 25 who also had similar struggles as a teenager, but now is a bit on the other side, but not so old that they're that removed from it, they can still relate. And then the parent of that child would get connected with a family support partner who's a person who's raised somebody that struggled with severe mental health disorder and understands that whole journey. And they meet with them on a weekly basis. And then everyone comes together monthly with a facilitator who brings together natural supports. And it could be extended family, coaches, neighbors, people from the church. We had one family that used an old babysitter that was re-engaging with them. In addition to all the professionals, which could be child protective services, the hospital, the school, family practice doctors, psychiatrists, a wide variety of people coming together monthly for these determinations of what the family really determined to be most important to them, where we're living well, what was their vision of what that meant, and interpreting that very intentionally. And training and support of the peer supports in this model is crucial to make sure that they can do their job well as well. So here's a slide from the initial pitch to the foundation, because this was originally funded by the foundation in a 2-year pilot. So the vision was to use this highly structured peer support model to really make life, living life better for the families, with the idea that this could be replicated to other chronic conditions. So this is the idea. We're going to teach people how to fish. So this is not Jeremy Wade from River Monsters teaching somebody to fish. This is somebody who understands, that has really been through it in being the coach alongside these folks in the model of sharing lived experiences and what lessons they have learned. So one of my peer supports summarized her role so beautifully. I said, I'm going to start stealing that from you. She said, I really see my role as 2 things: normalizing the emotional response to this experience in everything that entails, and building people's confidence up that you actually can do this through sharing what I've done in my own life, which I thought was just the perfect summary of how to talk about this. So in the mental health model, I just have to say, as Dr. Schreiber was mentioning, this is really designed for kids that are suffering the most. These are kids that were ending up in residential treatment facilities, maybe not staying in school, lots of interaction with juvenile justice, child protective services. That's the kids that were doing well with this program. So the idea in diabetes that we also wanted to find the kids that are sort of what we call top of the pyramid. Better not say top of the triangle in Pittsburgh. That means something else. But these are the most complex kids, right? So what did that really mean? Because that's who we wanted to work with in the pilot. So I did describe the structure there on the right through my little speech here, but really we were looking to recruit for the pilot between 20 and 25 kids that were considered high risk, who lived in Allegheny County, who had type 1 diabetes for at least 1 year, and were between the ages of 11 and 16. Based on Dr. Libman's data, we know that that's when kids really started having the most trouble managing their type 1 diabetes. We defined high risk as well as kids that were having at least one admission to the hospital for diabetes-related reason in the last year, or had a hemoglobin A1C jump of 2 points or more in a 6-month period, which everyone here would know is pretty significant. So we were looking at lots of different factors with the evaluation piece of this, and a lot of them were diabetes specific, of course, A1C being one of them. Also, how were people doing with their diabetes management plan as determined by the physicians and the endocrine department? How are folks doing with their diet and exercise? But a lot of it on these questionnaires that were pre-posted and given every 3 months during the program had to do with resiliency and how competent people were feeling in dealing with their type 1 diabetes. So some of these screens are very well known, I think, to a lot, especially primary care doctors in the audience. The SCARED screen for anxiety and the PHQ-9 for depression symptoms. But these other ones were really important around diabetes distress, the Columbia Impairment Scale, and something called the D-STAR, the Diabetes Strength and Resilience Scale. So we gave these to both the children and also to the caregivers. You'll notice in bold these additional youth questions. This is really important. So there were additional questions that were made by the advisory board. We had a community advisory board that was imperative to the support and success of this program. And they added additional questions that were missing from these tools that really talked about parent-child and caregiver relationships, as well as the relationship with the diabetes care team. So this is where Dr. Libman was worried I was going to go off the rails, gushing and going over time, talking about how much I love these people, but I wanted to give them appropriate attention. So we recruited, as is done in the mental health world when they were working on the high fidelity model originally, a diverse and expert perspective based on lived experience. So we had 27 people, 9, and 9. We had 9 young adults on the advisory board who had diabetes as teenagers. We had 9 folks that had raised teenagers themselves, and they were the caregivers of teenagers at some point in the past. And then we had system representatives. So we had the executive director from Western Pennsylvania ADA and Juvenile Diabetes Research Foundation, now known as Breakthrough Type 1. We had child psychiatry. We had a high-up person from the health plan who dealt a lot with diabetes issues. And everyone came together on a monthly basis for 2 years. They helped recruit and interview the initial workforce. They attended monthly meetings, and they gave a lot of input based on their expertise. And really always helped us with the focus on what the largest needs were to the family, what the child and the family caregiver can identify, which is really how we all live. Like what's most important to us, that's going to be the thing that we talk about and prioritize. And once we understood the basis of these needs, we can then listen and respond in the most helpful way possible. And I really felt like they kept us centered on this. So this is grand rounds. Why are we here? Of course, this is exciting to talk about the results of the pilot. So as you might recall, we were looking to recruit between 20 and 25 children. We recruited 21. Lots and lots I could say just about this slide, but I do want to mention the mean hemoglobin A1C at entry was pretty high at 10.5. These are teenagers with an average age of 14. These are not spring chickens to diabetes. The average amount of time that kids had diabetes when they enrolled with us was 7.5 years. and yet here they are struggling so much. And struggling a lot as you look there, only about a quarter of the kids were on a pump at the time of enrollment with us. So that's who we were working with. And no surprise here, the problems that a lot of these kids presented with, I think a lot of people here might guess, trouble with emergency room visits, hemoglobin A1C levels, a lot of struggles with diabetes care at school, but also you'll see here depression, anxiety, conduct issues, hyperactivity, learning disabilities. But there's some other things here that are pretty big hints, and probably the next slide is going to be the most important one of the whole presentation I make here. I'll hint at it here. High-risk environment, caregiver mental health being 30% of the kids we worked with is a little bit of a point. So I'm just going to sit here for a few seconds and let this next one kind of soak in. This was our pilot group. So think about the patients you care for and really imagine these 21 families. These are the homes and situations these kids had. And now imagine that this child has type 1 diabetes. Now, I have enough gray hair to know that this can be really heart-wrenching. And, all these kids have names and faces for me. And it can be hard. It can be hard to be optimistic. It can be hard to want to make a real impact for these kids and feel like you can't do it. Yet this structure we know works with kids that are struggling the most. And when we go through the data, I really want people to think about that this is the background of who we were working with. These are the ones that we can feel lost, I think, as physicians in how to make an impact and feel like there's no answer. But this program has demonstrated that there is an approach that can be truly impactful in a long-term and meaningful way. And that's what I want people to learn from all this today. So let's talk about this. As you might remember from recruitment criteria, a lot of the kids we recruited had a hemoglobin A1C that was bouncing up by 2 points or more in a 6-month period. During our program involvement, 63% of the kids had an improvement of their A1C, and at least 11% of them weren't getting worse. So 75% of the kids were a lot better off just from an A1C perspective alone. And I think about this one. So again, this takes time. These are weekly visits of very intense conversations with the peer supports working with these families. And in the first 6 months or so with this particular youth, A1C was staying right where it was, almost at 11, right? But then with time and trust and learning and readiness and motivational interviewing and appropriate support that feels supportive and not punitive, made a huge difference with this child. And in the last 3 months of the program, we saw massive improvements. I was a middle school teacher for a brief stint before medical school. So sometimes I really enjoy these easy to understand charts. And and I'm going to talk about this to make sure everyone gets it. So we looked at the admissions and ER visits for these participants. The blue column here is how many admissions were the kids having and how many ER visits were these kids having in the entire year before we ever started working with them. So looking at 21 kids, they had a total of 29 admissions for that year before working with us. And then in the time that they were working with us, which averaged about, a little over between 7 and 9 months, they really cut the admissions in about half. And then that gray column says, okay, what about the year after we discharged them? They haven't been working with us for an entire year. Did they bounce back to where they were, or did they evolve? Did this program have long-lasting impact? And again, thinking about all those green lines I showed you, in that whole year after working with us, these families were still doing about 30% better with admissions, which is incredible. And the ER visits, a little less dramatic, but again, sustainable change in the ER admissions, about half that they were having before working with us in the year after working with us. So I really want to talk about this because this really impressed the UPMC health plan and ended up being a really crucial finding in the sustainable funding for this project. Dr. Schreiber referred to this, and so did Dr. Libman, that diabetes distress and interpersonal relationships within the family is a huge part of what the struggle is with the A1C levels and admissions. In the surveys that we were doing around caregiver distress, we had a pretty big decrease from 58 to 32% as measured by the standardized tool. But what were the kids saying? What were they saying about this? So they had a ton of improvements in their knowledge, but also how things were going at school. The difficulties managing diabetes while at school decreased from 41% to 18%, as reported by both the children and their families, which had a lot to do with communication with school nurses and coordination with the clinic, but also being open in communicating. The youth were responding very well to our peer supports and reflecting that in a much better understanding of their carb ratios and correction factors, just as too as many aspects of the data. But this was a key finding too that came from those surveys that the advisory board had created. And I love the way they asked some of these questions, like how comfortable did the kids feel sharing with their caregivers that they weren't doing the right thing with their diabetes? Can you talk to your parent about that or not? So at the start, 30% of the kids said they were willing to share, and by the end that increased to 50%, 57%. And how do they feel about just sharing information in general? And those of us in the room raising teenagers would love this data. 58% of the beginning said, yeah, I can talk to my parents about a lot of things, to 89%, which was a huge difference to us. And there was also a big increase in how comfortable the parents and the children felt in communicating with the clinic. So there was a big increase in feeling like they could reach out to the clinic when they were feeling overwhelmed. So really helping develop that relationship and feeling safe and trust was a huge outcome of this work. So now I want to talk about these really creative community partnerships in the advisory board. This is probably what I like to talk about most. So Melissa Adamson, who was this amazing facilitator for the diabetes wraparound program, who I knew was online watching us, said to me once, you know that Phipps Conservatory has a test kitchen. I wonder if they would work with us, with the kids, on doing some cooking classes. And I thought that sounded a great idea in March of 2020. And this was really incredible. So we ended up to flipping in April of 2020, when a lot of us didn't even know what Zoom was, to this virtual cooking classes that were funded by Phipps Conservatory and Let's Move Pittsburgh, with 25 kids in this age group of the kids in the pilot. So we did offer this to all the families in the pilot, but also advertised it at large to kids in the clinic. We were able to attain the ADA's diabetes camp list, and had the participation of a chef from Phipps, a diabetes educator, a dietitian, and the medical team. And seeing all these little faces on Zoom cooking was just amazing. I have to give a credit to my advisory board. There is an example of the groceries. So we would separate out all these ingredients and drive them all over Pittsburgh, everywhere from McKees Rocks to Monroeville. We enrolled anyone that was within an hour drive of the hospital. And I'll tell you, the first time I dropped off a red pepper in April of 2020 to a kid living in Beltsuver, the smile I saw on her face, this was like, this is the right thing to do. I know that this matters. But of course we can say this, and this is Grand Rounds, so we've got to show some data. Okay, so the outcomes of the participation, the families were thrilled. They were super impressed, and saw that kids were having interest in living better with regards to eating, cooking, even exercise, which was kind of surprised me a little bit. The parents were 100% satisfied. One of my favorite outcomes from this was one of the kids ended up enrolling in culinary school. When I told the chef this, she literally was in tears. So we made some long-lasting impacts on people, and we're actually able to replicate this for 2 future groups of kids with cooking classes. So really this showed us, which is a huge part of the wraparound program in general, is the value of social connection and the kids seeing each other on this. These pro-social components are really vital in dealing with chronic illness. So we started thinking creatively. We're actually able to work with the Pittsburgh Penguins Foundation to do some free ice skating events for people with type 1 diabetes. There's some familiar faces there. There's some of my team members on the left, and Olivia Nori, who's a nurse with the endocrine department, who was also part of our advisory board. And our first one of these, we actually got 100 people coming to ice skate. One family drove from 2 hours away just to meet other families they wanted to ice skate with in 2021 and have that connection. One of my favorite stories from this event, we had 2 families with little girls of similar age that were in the same neighborhood that did not even know that they both had type 1 diabetes, and that led to a lifelong relationship. I've actually seen these families talking together at picnics. It's been amazing. We were also able to do an outreach to do some outdoor deck hockey as well. And just other creative problems. So I was sitting in the hospital recruiting a family for this program, and the mom he was looking so sick, and the mom was showing me pictures of this child in his athletic competition. And I thought, God, wouldn't it be great instead of every time you come to the hospital, you feel how sick you feel and how there's something different about you instead of what's going on well in your life. So part of what we did with an outshoot of this, and we offered this to kids in the program, but also the endocrine department in general, was to create this art project. So now when you walk into the diabetes clinic on the 3rd floor, you see all these pictures of kids doing healthy things with their type 1 diabetes and not just thinking about their ketones or urine checks. So we had, a big reception for the kids who won this contest. And this was one of my favorite, about this little one. She said, her mom said, she was so happy to see not only herself here, but was feeling inspired looking at pictures of other kids with type 1 having fun. And that's what this was really about. And that's a lot of what I've learned. So back to the advisory board accomplishments. They created so many different things for us, all kinds of handouts that we use. One of my favorites was, how to talk to your teenager with type 1 diabetes, things I wish my mother would have said instead. And this really cool tool that can be replicated for other disease states that was all made by the parents and adults and young people with type 1 on the board. What would I put on one page, front and back, about my diabetes if I could put it all in one place? We use this a lot with our families. We use it a lot with kids in transition age. And this has been one of the most powerful tools that we have. So last thing I'm going to say before Ingrid comes back up, we were able to publish a paper actually about the success of the diabetes advisory board, and I'm really happy to talk with anyone further about this. So to explain this further, the squiggly line, the way I like to explain things. So basically what we did was we had surveys at the end of these board meetings every month for 2 years that really talked about the good, the bad, the ugly. How did I do running it? What did you think? What did you like about it? What didn't you? And then we would send out the results of these surveys anonymously, of course, to the board. And then I would start the next meeting being like, I looked at all you had to say, and here's what we're going to do differently based on what you told me. Also, if people missed meetings, I would say, hey, I noticed you weren't there. Are you feeling well? Are you okay? I know that you're in nursing school. How are things going? And really find out very specifically what people could add to the board, and making sure people knew a bit about what they could. I knew that they could offer something specifically, and really understanding the strengths of each and every board member. So a big thanks to them. So I just want to end where I started, which is why this has been so rewarding for me. I appreciate so much my team, and this is not just a job for them. This is something much further. And especially with the families that have had some of the hardest struggles that I mentioned, that if we are able to build confidence in people, that's what's really key about this. So with this structured peer support and being open to understanding and really listening to what matters most to the child and to the family, and learning who else is in their family that might be able to help them long-term on this journey, bringing people together is really key in helping any family to get closer to what their vision is of living a healthy life. So with that, I'll hand it back to Ingrid. I'm sorry, Dr. Libman.
Thank you. So we are almost done. So in summary, the type 1 diabetes wraparound pilot demonstrated that the wraparound program used in mental health could be successfully adapted to support families severely struggling with a chronic condition such as type 1 diabetes. Utilization of a peer and family-focused model adapted from the behavioral health arena seemed to be efficacious in improving hemoglobin A1C and the number of admissions. However, as Amy was telling you, change doesn't happen overnight. This is really a time commitment and is a result of a well-trained, committed task force. Addressing the mental and social health of families struggling with chronic medical conditions in their child is vital to improving the physical health. you will be happy to know that an additional 75 youth and their families have participated in the program to date. And we are right now looking at all this plethora of data and questionnaires and evaluations that Amy shared with you. And we are very excited about this. And we want to end with some comments about the program and some thank yous. So this is a comment from a primary care doctor in the physician, not in the UPMC system, that has a patient that she mentions was being admitted every 6 to 8 weeks, sometimes even more frequently for diabetes-related admissions. And she writes to thank us because in the year after going through the program, this kid did not have any diabetes-related admission. So she really talked very highly about the team and the work they had done. These are some comments from members of our medical team here at Children's, talking about the wraparound program providing a unique support to help bridge the gap between when the patient is seen in the hospital and when the patient goes home, and talking about families receiving this continued support. And then another member of our team saying, the wraparound program has become one of the most useful tools we can offer to our families, and I'm so grateful for the support that the program provides to our most vulnerable patients, like Amy shown in her presentation. So we want to end with some thanks. First, we want to thank all our team members, and in particular, I'm going to name them because without them, there would not have been a program. Melissa Adamson, Jenny Kirk, Abigail Hartman, Christy Kessler, Victoria Robinson, Abby Hoover, Christina Beato, Zane Grimm, and Courtney Kelly. These are all facilitators, youth support partners, and family support partners. Without them, I want to say there would not have been a program. I also want to recognize all the work of the people that were involved at different stages, especially people from the Youth and Family Training Institute. And here I also want to recognize Amy Nevin. Without Amy as program director, I truly believe we would not have had a program. So I'm very thankful about that decision that I made at one point to bring Amy on board that came from us working together in residency. So again, who you work in residency may have consequences in life. And I want to thank the division of, or we want to thank the division of pediatric endocrinology, because without the referrals, without working together with us, with every kid that they refer, again, this would not have happened. And last but not least, we want to thank those who believed and believe in the program and actually provided or provide the funding to support it. And as Amy was saying, this started with an initial funding from the Children's Hospital Foundation from a family that felt very personal about this. They really felt that this was very much needed, and they provided the initial support, and we are incredibly grateful to them. There were other people, like my type 1 buddy, a former patient of us that also contributed. He felt that this was very important to him. Individual donors, Area Health Education Council, the Hillman Foundation, Beckwith Institute, ACHD Community Health Worker Grant, who actually funded, after us submitting a grant, some of our peer support partners. And then the UPMC Health Plan, who in the last years has really been our partner. They really believed in this. They continue to believe in it. And without them, we would not have a program right now. So thank you to everybody. And thank you to all of you for coming in the cold. And thank you to all of you joining virtually. Thanks.